So good morning, everyone. So my talk is going to focus on nocturnal enuresis and daytime wetting in relation to a little bit about etiology. I think Katrina has covered some of it. And I'll tend to focus a bit more on the management aspects. And there'll be areas within that which is being covered by the other speakers, and I'll say that that's just going to be discussed subsequently. I'll take questions at the end. Thanks. Now, I won't go too much into terminology. We've just had an excellent overview from Petrina. Just in relation to nocturnal enuresis, highlighting the importance of differentiating monosymptomatic from non-monosymptomatic. So monosymptomatic is essentially a child who is a bedwetter but has no daytime urinary symptoms, as opposed to non-monosymptomatic is the child who is a bedwetter but who also has either daytime urinary urgency or wetting, void postponement, and so on. And interestingly, we have children who have significant daytime wetting and parents present with that as the primary concern. But you'll also get children who are bedwetters where the daytime symptoms aren't mentioned unless you really ask specifically about them. And that's important because you would want to address those before you can try and overcome bedwetting. So in relation to enuresis, so the etiology revolves around an interplay of sleep arousal, nocturnal urine production, and bladder capacity. So you can have a child who is a very deep sleeper, and that's certainly a very common scenario amongst our enuresis population. And that combined may or may not be combined with a child who's got a small bladder capacity, either because the bladder is intrinsically small or because of related factors like being constipated or like having irregular habits around voiding and fluid intake. And then you will occasionally get the child who actually has large urine outputs overnight. In relation to comorbidities, it again comes back to contributing to the interplay of these three factors. So excuse me, any disturbances with sleep, so sleep disordered breathing, obstructive sleep apnea, the child who's got upper respiratory symptoms impacting on quality of sleep. Impacts on your quality of sleep and hence sleep arousal later, and I think Karen Waters is going to go into details on that side of things, but even simple things like a child who's got an irregular bedtime or teenagers who are going to sleep at 11 and then overly tired through the night and struggling to wake or respond to their bladder. Constipation, and I think this talk is going to be covered by Petrina, but constipation is known to influence lower urinary tract symptoms both in terms of daytime and nighttime. And we just find that, as Petrina said, a large number of children who have behavioral comorbidities, ADHD is one of the very common ones, but you can also get children with anxiety, oppositional behaviors, and other behavioral disturbances who also have wetting. And whether one's contributing to the other or they just have a common neurobiological origin is something to be debated. But the fact remains that if you have a child who's got daytime or nighttime wetting, you do want to explore what's happening around other areas, development, behaviors, school, social, parent-child dynamics, and so on. With regards to daytime wetting, so daytime wetting can be multifactorial and every child is different, and it all comes back to taking a detailed history to find out what's going on with this particular child. So you may have a child with an overactive bladder, which essentially means that the bladder the child has strong sensations of urinary urgency at small bladder volumes, and this, as I mentioned, could be an intrinsic bladder characteristic for the child, but there could be contributors such as constipation. We often get children who are void postponers, and as I tell parents, in my experience, every child I see is a void postponer to some extent or not, but if they have a small bladder capacity or an overactive bladder, then the bladder is a bit unforgiving and they will wet. You can have dysfunctional voiding, which is the child who doesn't empty when they void. And again, this could be related to behavioral aspects around how they void, toilet posture, whether they take enough time. And the typical scenario is the busy child who will zip in and out of the toilet without taking enough time to ensure correct posture and enough time to empty. And often eliciting that history and then putting in measures to address that behavior will give significant improvement. But you can also have the child who actually has a bladder that is not emptying for various reasons. And this could be related to a urological abnormality, and I'll leave Ani to talk more on that. Vaginal entrapment is something you'll see in girls from time to time, and occasionally if the child is overweight, and it's basically there is entrapment of urine in the vagina, which then leaks out, and you can get a post-void dribble. Pollakiuria this is usually a transient self-resolving condition. It may be present for 6 months or so. You have the child who was voiding normally, not wetting, and suddenly has this increased urinary urgency and needing to go to the toilet repeatedly. And as I said, it's usually a benign self-resolving condition, but the importance is that we have to differentiate it from a child who may be manifesting symptoms of diabetes or urinary tract infections, and you may have to investigate it. Giggle incontinence, again, interesting condition that you'll see from time to time. And this is the child who's dry during the day, except when they have a sudden burst of laugh, and that'll cause them to wet. So this is wetting very specific to a particular situation. And often they'll come and tell me it only happens when I laugh with this one particular friend. So the fix is, again, around addressing pelvic floor, in addition to ensuring correct bladder hygiene measures. And at times, you need to use Ritalin stimulant medication, which is known to work for giggle incontinence, though the mechanism is not known. So children with diabetes insipidus, may present with increased urinary frequency, and so that condition has to be kept in mind. Also diabetes mellitus, I would say. Idiopathic hypercalciuria, rare but seen, and this child will present with urinary urgency, occasionally dysuria. Wouldn't recommend doing a calcium creatinine ratio for every child with daytime wetting, but if you have a non-responder, then it's a condition to consider. I'll let Ani go into details of urological conditions. And then there's a child with a neurogenic bladder. And again, one has to just be alert to the red flag. So continuous dribbling as opposed to intermittent wetting would be a big one. In your examination, looking at the neurological side of things, gait, tone, spine, looking for any neurocutaneous stigmata. So with that in mind, I guess the history becomes somewhat more evident around points to cover. So background medical, as I mentioned, you would want to go into details of the child's development, any behavioral concerns. Was toilet training particularly difficult? And interesting, often enuresis or even daytime wetting can stem from a child who has had a difficult period toilet training. And sometimes that coincides with the birth of a new sibling, and there could be other psychosocial stresses, parental separations, anxiety at school, and all of that can contribute. A family history of wetting, as everyone knows, that enuresis has a strong link with genetics, and so also there is a link between daytime wetting and bladder conditions and heredity. Nocturnal enuresis, we've talked about delineating whether it's primary or secondary, what's the frequency of wetting, amount. Does the child actually get up in the night to void, or is this child a very deep sleeper? What's the bedtime routine? Are they going to bed on time? What is the sleep hygiene like? Is this child a restless sleeper? Do they snore at nighttime? Daytime symptoms. So as said, if this is important, even if a child presents saying that my child bedwets, you still want to go over the daytime symptoms, as there will be the child when you elicit the history. Yes, there is dampness most days. So if there's urinary urgency, is it related to void postponement? As in, the parent can see that the child employs void withholding maneuvers and then rushes at the last minute, or is this the child where the urgency of sudden onset? Urinary stream, again, does this child have a normal, strong urinary stream, or is it intermittent, slow? Do they have a sensation of complete bladder emptying when they're finished? What is their toilet posture? And again, I talked about this. So is this a child who rushes in, rushes out, sits forward? and it's done, or taking sufficient time, correct posture. I would also go over this in relation to bowel motion, so sitting back, having a stool for foot support, and going over those sorts of things, and whether there's a history of recurrent urinary tract infections. We cover fluid intake, making sure that the fluid intake is adequate, which most of the times isn't. And also, you'll often get the child who doesn't drink all day and then drink large volumes in the evenings. And that, of course, makes work hard at night for them. Comorbidities, presence of constipation, and we'd go over the Rome criteria, and I'm sure Petrina will go over this, but parents often dismiss constipation, especially if the child has a bowel motion every day, but when you go into the details, you find, well, they have a bowel motion every day, but there could be a Bristol type 1 or type 2 stool, and that suggests incomplete bowel emptying, which would impact on wetting. And importantly, what's the child and family's attitude to wetting? Because if you have a child who's a bedwetter at age 7, who's not overly motivated to be dry, then trying to instate measures like alarm training is going to be an uphill task and cause a lot of frustration for the child and the parents. And then when this child is, say, 9 years of age and possibly wanting to get dry, they've already got a bad taste around alarm training and they don't want to do it. So if you've got a highly motivated child at that age, you would go down that route, but if not, you may do other simple things like behavior modification and wait a while before approaching alarm training. And then again, what's the parents' attitude? So that's covered in another talk, but parents can have a whole range of emotions in relation to a wetting child, and it's important to get a sense of what's going on, and sometimes we need to normalize some of what's happening before we can take a step forward. Examination is standard, and as I said, we want to make sure we don't miss any neurological signs. Examining the perineum to look for any soiling, any excoriation, and in girls for any labial adhesions is important. Petrina has gone over the bladder diary and renal ultrasound, so I won't go into the details. We generally want a renal ultrasound in children who have daytime wetting symptoms or enuresis that is non-monosymptomatic, so with daytime wetting symptoms, and importantly, try and look for complete bladder emptying. So coming to management for enuresis, so the initial step would be behavior modification. So we try to keep the treatment graded and stepwise instead of throwing everything at the child all at once, which is all too hard for the family to take. So starting with optimizing and redistributing their fluid intake, drink well, drink more during the day, and restrict fluids in the evening. Make sure that you void every 2 to 3 hours, and for the child, I often say that generally means doing a wee after every meal, so after breakfast, recess and lunch, after school, after dinner, bedtime, and take care to have the correct toilet posture and take care that you take time to empty your bladder. Treat the daytime symptoms first, as I mentioned. So you would address void postponement, make sure there's correct toileting posture, and if this child has significant overactive bladder symptoms, then consider a trial of anticholinergic medications. Constipation will be discussed at the next talk, and alarm training is going to be discussed further down, so I won't go into details, but you would address constipation as well as part of your initial management. And when the child and family have gone over the behavior modification and done the daytime things and hopefully improved in terms of daytime symptoms, we bring up alarm training. Desmopressin, so a word on desmopressin, it's not a cure. It's good as a short-term measure. So you have the bedwetting child who comes to you and says, I have school camp in 2 months and I don't know what to do. And you think that, well, he's not going to be dry in 2 months. So it's a good measure for short-term, 2 or 3 days school camp sleepovers, or the child who's doing alarm training and has been doing alarm training for weeks to months and just needs a break between alarm training. And at times when they've been doing it for a long time and they're tired and they want a break. So those would be the main indications for desmopressin. So a little bit more about Minorin. Earlier used to be the nasal spray formulation, which is no longer recommended. More chances of overdosing and then developing fluid overload and water intoxication. The oral formulations are quite safe, provided the family needs to remember that the child has to restrict all fluids from an hour before they take the medicine until the next morning. And I generally get them to repeat that back to me just to make sure they've got the message. It comes as tablets and melts, and the dose would be for tablets 200 or 400 milligrams at bedtime, for melts 120 to 240, and it's generally well tolerated. As I mentioned, used on its own, there isn't a guarantee that the child will be dry when they stop taking mineral. Treatment for daytime urinary incontinence, so addressing the triggers, and from history you get a good sense of what are the triggers for this child in particular. So we've gone over addressing regular toileting, address constipation, make sure that there's correct voiding techniques. If it's overactive bladder symptoms, ensuring adequate fluid intake, and if necessary, anticholinergic medications or neuromodulation, to be discussed again later, and rule out if there are any possible anatomical or neurological causes that are triggering this child's wetting. So coming to anticholinergic medication, Ditropan or oxybutamin is the first-line pharmacotherapy. It's been well studied and it's PBS approved. So the dose would be anywhere from 2.5 milligrams to 5 milligrams, taken twice or thrice a day. It also available as a patch formulation, and this is probably suitable for the child who is not yet comfortable with swallowing tablets. Probably the oral formulation is more effective. Some children will exhibit side effects, and the most common ones include dryness of mouth, sweating or decreased sweating or facial flushing. Incomplete bladder emptying is something to watch out for, so you want to have an ultrasound at some stage to make sure that they're still emptying their bladder completely. Constipation and CNS side effects can be particularly troublesome, with dizziness, tiredness, mood changes. And if the child is experiencing these, you would take them off that medication, and there are newer, more bladder-specific alternatives which are currently off-label, but they are seen to have a better tolerance profile with children. So just as an overview, the detailed history is the key. Investigate, as discussed. Set in a graded approach instead of trying everything all at once, which can be quite overwhelming. Make sure that constipation is addressed. Consider anticholinergics in case of overactive bladder. Relaxed voiding techniques are important. Alarm training is the treatment of choice for enuresis. Desmopressin is an aid, and stay on the alert for comorbidities. When would you refer? So if you've tried standard therapy and the child is refractory to treatment of over 6 months for enuresis, if they have daytime symptoms that are particularly complex, or if you're suspecting any urological or neurological abnormality, or if there are significant comorbidities. Thank you.